Alrighty, so I'm going to start the presentation with some clinical information about sleep and autism and how we can try to improve sleep. Paige Townsend, who is a Landreth Research Fellow at the Lurie Center and with Dr. Dara Minowick, is going to talk a little bit about the research she's doing and the physiology of sleep. And Jacob Hooker, our scientific director, is going to moderate a discussion. So let me just start and say we'll start about and talk about sleep and autism, and then talk about sleep hygiene, which is the behavior techniques we use to have good sleep, falling asleep in a dark room, not watching TV when you're falling asleep, and some behavior strategies that can work for people. I think you all know that sleep difficulties are really common in autism. And that is one of the most frequent calls that we get in the nursing station. 50 to 80% of children with autism have difficulties falling asleep. And that's almost twice as much or more than twice as typical as in the neurotypical peers. So normally we want to fall asleep within 20 minutes. Culturally appropriate, sleeping alone. And there are many, and typically you should fall asleep and pretty much stay asleep the whole night. We all wake up a little bit and then we fall right back to sleep. And children sleep between 8 and 11 hours, typically. There are many factors that can impact sleep, our neurology, behavior and learning, as well as medical issues. The problems that kids have with autism are persistent, and they can change over time, but it's really hard. It's a big problem for many children with autism, and they have difficulties falling asleep, staying asleep, or waking up too early. Teeny bit of science. GABA is a neurotransmitter, and the neurons that secrete GABA are disrupted, and they may play a role in stopping the brainstem neurons that are associated with wakefulness. There's another neurotransmitter, serotonin, that may be increased in some children with autism, and that's wake promoting. And melatonin, the hormone that helps us to feel tired in the evening when it's increased, is a little bit lower in children with autism than in typical people. So that's why many children are given melatonin to help them fall asleep. So if the child isn't sleeping, the parents aren't sleeping. If the child, and that can lead to a lot of problems in the family. If you live in an apartment, it can affect the other people who are living in the house. In the child itself, we see aggressions, self-injury, hyperactivity, inattention, more repetitive behaviors, worse social communication, and family stress. I know if I don't sleep, I'm not very nice at times, and certainly it's much harder for children and their families if no one is sleeping. So we really try to work on it and address the sleep problems as quickly as we can. So sleep hygiene is the behaviors that we associate with sleep, like exercising so that you're tired, having regular meal times, not drinking Coca-Cola or coffee just before bedtime. And what we try to do is set up routines or rituals. And routines sometimes are not good, but a short 30 to 40 minute routine that might include taking a bath, taking a shower, and even having a little schedule like I have here, all the different things you do before you go to sleep. Reading a book and not watching screens are all important. And there's some other tricks or strategies that some families will use. Light timers, you know, those old-fashioned things that you plug into the wall and so the light turns on and off, like when you're going away. Those can be useful. So a child might know when it's time to wake up because the light goes on in their room. Using visual cues, opening up the curtain so the child knows it's time to get up, or turning off the lights. Some parents have colored lamps, so when a lamp turns a color, the child knows it's time to get up. Some parents will give their children a pass as a means of encouraging them to stay in bed all night. And essentially they can redeem the pass for a treat if they stay in bed all night. And that can work well for toddlers or older children who have a habit of going into their parents' bed. One of the most important things about falling asleep and sleeping is that how you fall asleep the first time is how you're going to fall asleep the second and third time, because we all kind of wake up a little bit and then fall back asleep. So if you're used to falling asleep in your parents' bed and then they carry you into your own bed, you're going to wake up and go, whoa, where am I? I'm not in my parents' bed where I know how to fall asleep. And so the child will, you know, march back into their parents' bed. So you need to learn to fall asleep the way you want to stay asleep the whole night. If you're used to falling asleep in a car, then of course, I've had parents who drive around during the night so that their child will stay asleep in the car. And that is obviously not sustainable for anyone. So if you're okay with a family bed, then you can have, you know, a couple people in bed with you and just make sure the child stays there all night. But generally we don't want TVs going, and we want the room to be equally dark the whole night. It's okay if you have music or sounds that play, as long as they go on all night. Then they can go off when it's time to wake up, so the child knows. So when do you get help? So snoring can be a sign of disrupted breathing or sleep apnea, intense anxiety. If the behavior modification techniques don't work, if the child has reflux or seizures or constipation, those are things that we need to treat medically. Because when you have reflux, it hurts when you lie down. And so naturally, if a kid has bad reflux, they're not going to want to lie down because it hurts. They're going to wake up and want to get out of bed. Constipation, pain, restless leg disorder, which can be due to iron deficiency. So there are some reasons that you need to go see the doctor. And of course, don't forget those medications that can cause insomnia. Some of those are like Ritalin or Adderall, but there are other medicines as well. So medicines to treat sleep in children with autism. There are not a lot of scientific studies outside of melatonin. And there's no FDA-approved medication specifically for pediatric insomnia. Melatonin and clonidine are commonly used. But remember that when you give your child a medicine, you want to make sure they can tell you if there are side effects. And some children with autism aren't good reporters. So you have to be very observant for side effects. So as I said, melatonin is best studied. The other medicines that we use are clonidine, guanfacine, trazodone, risperidone, and iron or gabapentin for restless leg. And of course, for kids who have sleep apnea, they often end up getting a tonsillectomy and sometimes a CPAP device. So one of the most important things for sleep treatment is to make sure that both parents are on board with whatever treatment you're doing. Both parents are caretakers, because otherwise you're going to have arguments in the middle of the night. So have to agree beforehand what you're going to do for treatment and how you're going to manage it, and make sure everyone understands what the plan is. And when you try a medicine or behavior techniques, generally it's good to remember that specialists are sometimes needed. So Autism Speaks has some really helpful online toolkits. Toolkits that can promote good sleep habits. They have sample bedtime routines, visual supports, and sleep diaries if you want to keep track of it. So that's a great place to go look for extra help. So I'm just going to say, oh, actually, I won't even. So that's really the end of my talk. And I'm looking at the time thinking I talked too long. So now we're going to move on to Paige. And she's going to talk about the research, her research in autism. And I'm going to stop sharing. There you go.
Thank you. Let me go ahead and set up my screen. Okay. All right. Is everyone able to see my screen? Yes. Okay, excellent. Well, first of all, I'm really excited to be here to tell you all a little bit about the research that I've been doing during my time here at the Lurie Center. As Dr. Neumeyer mentioned, I've been working with her as well as with collaborators over at the Martino Center, specifically in Dr. Dara Minoak's group. So my research is really interested in understanding the origin of sleep disturbances that might be present in autism, with the hope that maybe if we understand what's going on in the brain, we might be able to develop more targeted treatments to improve sleep in this population. So how do we typically study sleep? In the lab, my research tends to use a combination of different tools and techniques. And each of these tools provides a unique piece of the puzzle so that we're able to get a better overall picture of what's happening. So for example, one of the tools that I'll use is questionnaires, which are really important for gathering information about an individual's actual experience during sleep. So this could include asking someone if they felt like they had trouble falling asleep or staying asleep across the night. I also use what's called actigraphy, which is basically like an Apple Watch that tracks movement throughout the night. You might have also been familiar with some similar technology on phone apps and things like that. And actigraphy is really useful for tracking sleep and wake cycles that might happen over longer periods of time. And then the final technique that I use is EEG, which is a non-invasive technology that records brain activity from little tiny electrodes that sit in a cap usually from the scalp. And what EEG is really useful for is providing us a window into the brain to get an idea of how brain activity is working. So using EEG, we're able to learn a little bit more about sleep stages through the night. So as we're sleeping, we drift between different stages of sleep. So obviously when we go to bed, we're initially awake and we start off by drifting into a lighter stage of sleep, which is stage 1, and then drifting further into deep sleep later on. As the night progresses, you also see what's called rapid eye movement sleep, which is shown here with this black bar, which is commonly associated with dreaming. So that tends to take a more dominant role later in the night. What we see when we're using the EEG is that brain activity actually changes as we're cycling through these different stages. So for example, it might look a little bit different when we're awake compared to when we're in deep sleep. Additionally, each of these stages of sleep has a different function. So my work has been predominantly looking at, here we go, a specific type of brain rhythm called spindles, which are characteristic of stage 2 sleep. And spindles are thought to have at least 2 different functions. The first one is helping with learning and memory. Spindles are thought to help convert new things that you learn during the day into more permanent knowledge over the night. Spindles are also really important for maintaining sleep. So there's been some research finding that the part of the brain that produces these spindles is also blocking out sensory information from our environment that might wake us up. So for example, noises around us. So one idea that we're testing is that potentially in autism, you might be seeing fewer of these spindles, which could be related to more arousals through the night. So EEG is really useful in being able to help us detect these spindles, but there's a lot of challenges that we face when it comes to using EEG to study sleep and autism. So for example, the majority of EEG studies have to be completed within the laboratory setting. And this can be really disruptive to nighttime routines, especially as Dr. Neumeyer was talking about a few minutes ago, the importance of kind of establishing nighttime routines to help with sleep hygiene. So it can be really difficult to come in to the lab setting. For some kids, coming into the lab or the hospital also might elicit anxiety and might be a significant barrier for participating in this kind of research. There are also some individuals with autism that might struggle sleeping in the EEG cap to begin with, as there's a lot of different textures taking place on the head. So those that have sensory sensitivities might have a more difficult time, or in some cases not be able to tolerate the EEG cap at all. And this is really a problem because conducting these sleep studies takes a lot of time, and it's definitely expensive on the researcher's end, but it also is very time consuming to the participants that are coming in. And so what happens is that we have these really small sample sizes that can't really capture the heterogeneity that's present in autism. So my work has been really trying to break down these barriers for participating in EEG research to study sleep. And the solution that we've kind of arrived at is using what are called wearable EEG headbands. So on the screen here, you can see what a normal EEG net would look like. And here is a picture of the EEG headband that we're using. So the EEG headband has a couple of aspects to it that make it really advantageous in this population. The first is that it can be sent home with families so that they can complete the sleep study in the comfort of their own home. Additionally, it's much smaller and more comfortable than a traditional EEG net. So it makes it a little bit easier for people to acclimate to wearing it. So this has been kind of the technology we've been using so far in my work. So the first step to this research has really been focused on the feasibility of this. Like, does this work? Can we actually record sleep at home in individuals that have autism? And this work, again, has been in collaboration with Dr. Dara Minoak and Dr. Mylonas over at the Lurie Center. So to test feasibility, we've been recruiting adolescents with autism to come into the Lurie Center. And when they come there, we train them on how to use the EEG headband. Then we'll send the families home with the headband with the hope that the child will be able to sleep with it for up to 3 nights. And so far, what we're finding is that it is feasible to do this. We've had 10 adolescents with autism that have so far slept in the headband for at least 2 of the 3 nights, with 9 of the 10 of them sleeping for all 3 nights. So this has been really encouraging, and we've been thinking about how to kind of expand on using this type of EEG headband at home for other studies of sleep in autism. So one of the directions that we're going is investigating the relationship between sleep and sensory processing. So we think individuals with autism might have difficulty filtering out sensory information in the environment. One example that you may have experienced in your life would be if you were asleep, you might not wake up if you hear something like the heater or the AC unit kick on. However, you might be waking up if you hear something that's really important, like your child moving or crying next door. So if this filter isn't working properly, it might look different during the day and in the nighttime. So during the day, this might manifest as being more overwhelmed by sensory information in the environment and difficulty kind of maintaining attention to the things that might be important around us. And at night, it might result in being more arousable and waking up more frequently. So in this study, we're measuring sensory processing by having participants come in and listen to different tones. And we're measuring how their brain is responding to those repetitive tones. And then we'll also send them home with the sleep headband so that we can measure sleep at night. We're also interested in using our headbands to understand the effects of melatonin on sleep. So melatonin is a hormone that is commonly used to treat sleep disturbances in autism. And there's a relationship between melatonin and spindles, that brain rhythm I was talking about a few minutes ago. So what we're hoping to test is whether or not administering melatonin might influence the number of spindles we see in autism. And then another exciting avenue we're taking this research is to include individuals with profound autism. So those who might be minimally or nonverbal, have intellectual disability, or have other challenging behavioral concerns or sensory sensitivities. So this group has systematically been excluded from research, especially in terms of sleep studies using EEG, because of some of those barriers I was talking about before. So to make this study a little bit more accessible, we've been working closely with Nicole Simon, who's a behaviorist here at the Lurie Center, to develop a desensitization training where we'll send participants home with a fake or mock headband to practice with before they complete the study. So the mock headband looks and feels exactly like the real one, but it doesn't actually record any EEG activity. So in case anyone's interested in participating, we are currently recruiting adolescents between 12 and 18, both with and without autism, to participate in this work. But for now, if anyone has any questions, I'm happy to answer them.